without any further ado, Dr. Felipe.
So, hello everybody. Thank you very much for the invitation, Mohannad. It's a great honor for me to be here, and I hope you enjoy our discussion. I have dedicated the last years of my career to HOLEP and gradually moved to a exclusive HOLEP practice. So I only do endourology right now. I still treat some stones because it was my main work before HOLEP, but I'm moving toward an exclusive HOLEP practice. I think the best results in any kind of surgery comes from dedicated surgeons. So if you have a robotic program, if you do robotic surgery every week, you are probably going to have better results than if you do once in a month. And I think BPH should move toward this direction. And I think for HOLEP, it's very important to be constantly doing surgery. So I'd like to share my screen. Can you see that?
Yes, we can.
Okay, let me just... So, BPH laser treatment, background, and new advancement in endoscopic enucleation of the prostate. I work in Pompeia Hospital in Caxias do Sul. It's in the south of Brazil. I was born in Rio de Janeiro. I did my graduation in Rio de Janeiro Federal University and my residency in Rio de Janeiro State University. But I have moved to South 12 years ago. So now I have the Enlarged Prostate Institute as my personal clinic, and I work only there. So we have from many players for BPH treatment. Some of them we are not using anymore, like tuna, but we have new players like Urolift, Reson, Aquablation, arterial prostatic embolization, and ITIN. But the long-term outcomes that we have are basically from TURP, enucleation techniques, and PVP. But the gold standard is TURP because it's cheap, it's reproducible, and you avoid abdominal incisions. But TURP has many limitations. The first one is hyponatremia or post-TURP syndrome, especially in monopolar TURP. You may have fluid absorption, and this is a limitation for larger glands because of the surgery durations. We have bleeding, especially in larger prostates in patients under anticoagulations. And you have the problem of durability. With long-term monitoring, we have more reoperations if you don't remove the adenoma completely. And you may damage the urethra with the standard resectoscope, and you have some patients with urethral strictures. So the limitation of the gland size is related to the resection efficiency. On average, with a standard resectoscope, you can remove 0.5 grams per minute. If we consider the peripheral zone as 15 to 20 grams, if you have a 60-gram prostate, you have 45 grams of adenoma. It will take around 90 minutes. And with an 80-gram prostate, you have 60 grams of adenoma. It will take 2 hours. And with the standard 26 French resectoscope, you have a 24 French loop because it has 2 sheets, an inner sheet and an outer sheet, so you can have the continuous flow. So you can't downsize the 24 French loop without compromising the resection efficiency. So probably we can't decrease the urethral trauma very much with our standard TURP equipment. If we analyze the impact of surgical durations on complications, we have this nice paper from 2018. They have evaluated 31,000 surgeries and divided in groups according to OR time on groups of 30 minutes. So it's 0 to 30 minutes, 30 minutes to 1 hour, 1.5, and more than 2 hours. And what they have seen is that complications increase after 90 minutes of surgery for TURP. And this is true for infectious complications like sepsis, transfusion. So increasing the surgical time in TURP increases complications. If we take the multivariable analysis, you see that over 2 hours, you increase all complications, like you have an odds ratio of 1.6 if you have more than 1.5 hours, and 2.4 for more than 2 hours of surgery. And transfusion is more dramatic, 4.5 the odds ratio for more than 90 minutes, and 7.5 for more than 2 hours. So the conclusion of this paper is that TURP is safest when performed under 90 minutes. So you can't go too large. If you analyze another nice paper with over 10,000 patients from Germany, they have compared resection weight versus complications. And if you take more than 60 grams of tissue in TURP, you have 9.5% transfusion rate, or an odds ratio of 5, and 3% of TURP syndrome. So the EAU guideline for large prostates over 80 grams do not recommend TURP. It's the last option. Concerning durability, there is this nice paper from Canada with over 45,000 patients of TURP and almost 7,000 patients in PVP. 52,000 patients from 2003 to 2016. And the absolute risk of reoperation to need a second TURP was 11% for TURP and 13% for PVP. The event rate was 2% per year for TURP, or that means that in 10 years, you would have on average 20% of chance of reoperation and 3.36% for PVP. So PVP has 57% more chance of needing a second surgery in the long term. But concerning transfusion, laser vaporization is much safer. The absolute risk of transfusion in the TURP group was 2.6%, and in PVP 0.6. So you have a 76% reduction in the risk of transfusion, and most of the patients were performing as a day case. Now, concerning reintervention for strictures or bladder neck contractions, both groups had on average 11% of reintervention for stricture or bladder neck contraction, which is, for me, it's too high. If I had to do surgery in my prostate, I wouldn't like to have 11% reintervention rate. And concerning durability, this is another paper from the US in a large database, and the average number of surgeries in the US for BPH regrowth, so patient that already had a BPH surgery and need a second one, was on average 6 to 8% of all BPH surgeries in the US. So this is the aspect of the prostatic fossa 10 or 12 years after TURP. This patient was a 82-year-old patient that had a TURP when he was 70-year-old, and you see that the remaining tissue at the apex have grown as a large nodule inside of the fossa, created this valve mechanism. So even if you do a good job in part of the fossa, if you leave some tissue behind, in the long term, it will regrow, and this patient was in retention. So the solution for durability is the complete removal of the adenomatous tissue. That means enucleation. And you can perform enucleation open, laparoscopic, robotic assisted, or endoscopic, where we come to HoLEP. If we check the AWA guidelines for large prostate, they recommend only enucleation. And HoLEP and TULIP are size-independent options. So everything started with Peter Gilling and Mark Fraundhofer in 1998 with the development of the mechanical morcellator, the transurethral morcellator, and they did the first description of HoLEP. And you need a high power home laser. Most of the places use 100 watts, but you can do safely with 60 watts. And you need an end fire fiber. The most used is 550 micron. And you need a morcellator. Now we have many options available in the market. In the equipment, you need a laser bridge with a stabilizing catheter or a laser working element. And I personally prefer the working element because you can adjust the distance with your right hand, but many high volume surgeons, especially in the US, they use the bridge and the catheter. And most used is the 26 French sheath, the same of QRP. And for the morcellation, we remove the inner sheath, we keep the outer sheath, and we use a long nephroscope through this sheath with an adapter or a bridge to fit the outer sheath of the resectoscope. The first morcellator used from Peter Gilling was the same that we use today with the VersaCut from Luminis. It has reciprocating blades that works like a guillotine, and there is some risk of bladder damage. You have to be very cautious. You have to keep the bladder full all the time. It's quite noisy, and it has a very heavy handpiece. And the morcellation efficiency is around 5 grams per minute. Sometimes we have some beach ball hard nodules that are difficult to morcellate, and you have to change to a loop to slice the beach ball in the end, especially if you have a used blade. And the second generation of morcellators started with the Piranha. It's a rotatable blade. It's much safer because you can't bite with the back of the blade. It's lightweight, the handpiece, and much more silent. It has much more efficiency. It's around 10 grams per minute, sometimes even higher, depends on the kind of the prostate. Some prostates are more fibrous, some prostates are more soft. And now we have other options from stores that had a similar working blade, and some from China too. So Peter Gilling and Mark Fraundhofer described the HoLEP with the 3-lobe technique. But since then, we have dozens of randomized clinical trials from different centers providing level 1 evidence. We have some series with more than 10 years of follow-up showing its durability in the long term. We can find hidden carcinoma because you send all the adenoma for histology analysis. It's safe in anticoagulated patients, and we have many papers about proving that. It's cost-effective because you can use multi-use fiber. You have shorter hospital stay, so you save money in the hospital, shorter catheter time, lower transfusion rates, and is recommended by our main guidelines as the gold standard for large prostates. This paper comes from Canada, from Montreal, where Mohannad did his fellowship with Mustafa Ilali, and they have shown the reoperation rate for adenoma regrowth was 0.7% in 10 years. This is really unmatchable by any other kind of surgery. But the biggest problem for HoLEP is the steep learning curve. What are the problems for the beginner? There are not many mentoring programs available, So you have to move somewhere else to do a fellowship for 1 year or 2 years. You have a long surgical time. It's difficult to find and keep the right plane. You have problem to know exactly where to incise the mucosa of the sphincter. And you have the urethral trauma and the stricture, especially if you have a long duration of surgery. So between 2015 and 2017, we had this HOLEP Brazil project with my friend Rodrigo. And what we did was a self-taught learning curve. There was no HOLEP or endoscopic enucleation in Brazil. There was one machine used for HOLEP, but not largely used, only for smaller glands. The first guy was from Curitiba, Dr. Slongo, who bought his first high-power home laser, but there was no mentoring available. We did 3 visits of 1 or 2 days to high-volume surgeons. We went to Buenos Aires to see Mariano Gonzalez, to London to see Rick Poppert, great surgeon, and to Indianapolis, to Methodist Hospital to see James Lingman. And we started a problem-based learning. We started doing, if we had some problem, we went back to the computer, we searched on PubMed, all the descriptions of the technique. We watched many videos on YouTube. Now we have more options available. And we use Sci-Hub to get these papers. And what were our most common problems? In the 3-lobe technique, we start the surgery at the bladder neck level, dividing the median lobe from the lateral lobe. So we do this groove between the lobes from the bladder neck to the lateral of the Vermontano. So we start with the 5 o'clock bladder neck incision and the 7 o'clock bladder neck incision. And here was a big problem for me, especially because it was difficult to find the right depth. Sometimes you think you are okay and you still have adenoma, so you enter the adenoma and you lose the plane. You have bleeding from the edges of the mucosa, especially in patients under retention, because the mucosa of the prostatic urethra is hypervascular if you have a catheter for a long time. And you have to deal with the big arteries of the bladder neck at the very beginning of the surgery, at the bottom of the groove. So sometimes I spend a lot of time trying to coagulate ineffectively in these grooves. Then you connect both bladder neck incisions on the top of the vero. I have the picture of you in my screen. One moment. Yes, all better. Yes, and then when you are enucleating the median lobe, sometimes you undermine the bladder neck, because sometimes the bladder neck has a steep angle. You are doing like this, and then you have to lift 90 degrees, and you go under the bladder. And this was a big problem when I tried to do the 3-lobe technique, to have perforation. And then you do the hockey stick incision from below, and then the hockey stick incision from 12 o'clock. You do another groove at 12 o'clock, and then you do the downward hockey stick incision. But this is very difficult for the beginner. Where should you incise? If you go too distal, you risk to provide thermal damage to the sphincter. If you are too proximal, you have some adenoma penetration and you lose the plane. It's very difficult to recover the plane once you lose it. The secret for HOLEP is not to lose the plane. And sometimes and the next step is the division of the mucosal bridge between the upward and the downward dissection, and join both incisions. And here is another problem. Sometimes you go in different depths from below and from the top, and you never meet, and you take half an hour to find yourself where you are. And then you do the other side and you have the same problems. So in our problem-based approach, we had the long surgical time problem. So my conclusion is that every mistake you do in HOLEP, you pay with time. And bladder neck incision is the major source of mistake in my self-taught learning curve, and the major source of bleeding too, because the prostatic supply of the prostate comes from the inferior vesical artery, and then you have this urethral group of arteries that go at the bladder neck level, at the proximal prostate, into the adenoma. If you start the surgery here, you have to deal with these large arteries at the very beginning, and this is not the easiest way to do. So the first solution came from the videos from Canada, from Mustafa Ilali, and from our visit to Professor Lingman. With the two-lobe technique, you do only one bladder neck incision posteriorly at 5 or 7, depending on where the configuration of the prostate is easier. And you dissect the median lobe together with one of the lateral lobes. So it's median lobe plus lateral lobe on one side, and the other side only one lateral lobe. And you do the lateral dissection of the middle lobe, and you avoid the undermining the bladder neck if you come from lateral. And then you do the upward dissection of the lateral lobe, and you cross the midline from below. And then you avoid the second problem, that are the crossing planes laterally. And then you cut the 12 o'clock incision, but you don't have to search for the good plane anymore because it's already dissected. So you cut to the water, and you don't have to look for the plane another time. So suppressing one of the bladder neck incisions saves time, and you avoid many mistakes that you would pay with time. So doing this, we reduced our surgical time dramatically. The second solution came from the paper from Cesare Scofoni and Cecilia Cracco from Italy. It's the en-bloc no-touch technique. So basically, suppressing 2 bladder neck incisions saves even more time. You have the same benefits of the two-lobe, but you have a better spatial orientation, because the integrity of the adenoma is a surgical landmark. If you are a little lost, you go a little bit backward and you see the contour of the adenoma and you recover the plane. And after that, we stopped to missing the plane and leaving residual adenoma, or even having large perforations. And you can move into a totally in block, no bladder neck incision, which avoids bleeding, and you have better visualization. You have this large circumferential movement of enucleation with increased enucleation efficiency, and it allows you to make a complete preservation of the bladder neck, as I will show later in the video. The problem number 2 is how to find and keep the right plane. I have told you before that during the bladder neck incision, it's very difficult to know where you are, and to keep the plane is not very easy at the beginning. You may have a capsular invasion if you go into the peripheral zone, and there you have more bleeders. You have larger arteries of the capsule, and you have bleeding. You may have a capsular perforation that may cause fluid absorption, and you may leave some residual BPH tissue that will cause regrowth and compromise your long-term durability. The home laser is a pulsed laser absorbed by water, and it has 2 effects: the heating, the thermal effect, and the mechanical effect of the bubble. This bubble creates a mechanical effect that helps you in the dissection if you learn how to use this effectively. This slide is very, very important because it shows that Homeo is a short distance laser. If you are in contact with the tissue, you have maximum absorption of energy, and you have cutting effect. So if you are less than 1 millimeter, you are cutting the tissue. You can cut everything. If you push the fiber, you go outside of the patient. if you have more than 3 millimeters, you are outside of the thermal zone. You have absolutely no thermal effect. You may have some mechanical effect, but no thermal effect. It doesn't help in coagulation. So the key is to keep this right distance from the fiber teeth to the tissue. It's between 1 and 2 millimeters, where you have this coagulation effect and the mechanical effect. And the no-touch technique proposed by Scofoni and Cecilia Krakow is to explore the mechanical effect of the bubble, the Moses effect, and the accent coagulation with less energy delivered to the capsule, which may decrease dysuria rates. So basically, there are 3 ways to perform HOLEP. You can do a blunt enucleation, and even with holmium laser, you can do that. You can have like the 3 horseshoe technique from Arkadiusz Miernik. He used the blunt tip a resectoscope from Wolf, and he does a lot of blunt dissection. Professor Mustafa Ilali too, in his videos, we see a lot of blunt dissection, James Lingman. You have energy-based enucleation, where you are working in contact mode all the time, touching the tissue, and you have the no-touch technique. So the blunt enucleation is important in especially one moment of the surgery. On the lateral aspect of the veromontano is the easiest way to find the plane. If you push the resectoscope laterally, you will enter the plane very easily, but you will disrupt the vessels without any thermal energy, and you have more bleeding. So this is probably not very safe in anticoagulated patients, and it may compromise your vision, especially if you are using smaller sheets. The second way is the energy-based enucleation if you are working in contact mode. You see here in this video, you are losing the plane, you are leaving a lot of adenomatous tissue behind, and if the patient has hypocontracted bladder, or even in the long term, it may regrow. So you have this not so good appearance, and you may have capsular penetration too. So this is something I don't really like. And this is the ideal form of dissection for me, is the no-touch technique. You are working from 1 to 2 millimeters all the time. I call it the laser-assisted blunt enucleation. The tip of the sheath creates traction, and you use the bubble just to finish the liberation, using the right distance to have the thermal effect on the tissue. So you have to be painting the capsule all the time. You do the coagulation as you go. It's easier to keep the plane, you have excellent hemostasis, and this is the Columbus egg of endoscopic enucleation. You use this as a surgical strategy all the time, sometimes not so easy. That's why I like the working elements. So you have the enucleation and coagulation simultaneously as you go. And now we have pulse modulation from Lumenis. It's the Moses technology, and now the second version. Basically, you have 2 pulses, and the second pulse occurs at the peak of the first. So the energy goes into the bubble, and you have a longer reach. Quanta System from Italy has a similar technology, is the virtual basket. So from my knowledge, these are the 2 companies providing these pulse modulations. So in this video, you can see the optimizer energy transmission. In the first video, you see that the bubble goes until the red line, and in the Moses pulse, the second pulse reaches further. So the longer reach provides an easier coagulation. You can work a little bit farther from the tissue and still have the thermal effect. The virtual basket has the same principle. You have a short pulse and a second pulse with a longer pulse duration. And you have different pulse modulations. You can, for example, use a very long pulse duration, is the vapor tunnel from Quanta. You can have a longer reach with the virtual basket. And you have this bubble blast, which has more mechanical displacement. Sometimes it helps to infiltrate the plane and you can see where to go. But the biggest problems for endoscopic enucleation of the prostate are the complications, the transient stress urinary incontinence and the urethral restrictors, because patients may feel worse than pre-op. If the patient is in retention with a Foley, maybe he will not be so upset, but if the patient is okay, he has weak stream and he has some urgency, if he has to use a pad for too long, this is a real problem. And this is really important during the learning curve. So this is a paper from France, from Paris, from 2019, and they have reported their initial HOLEP learning curve in a single center with 8 surgeons using a 3-lobe technique. And they have reported 43% of the patients with incontinence in 1 month and 33% in 6 months. And most of the cases were stress urinary incontinence. And they have reviewed the literature. There are reports of 15 to 44% of incontinence in 1 month, 5 to 18% in 6 months, and up to 5% in 12 months. So this is not very safe if you are trying to start a HOLEP practice alone. The common explanation for the transient incontinence is that if you do a complete enucleation, you leave the sphincter unprotected, but we don't see that in open simple prostatectomy. We still do a lot of open prostatectomy in Brazil, and they don't leak for so long. Maybe this is the trade-off of endoscopic enucleation. To achieve long-term durability, the patient will have to use a pad for a couple of months, but not necessarily. So how can we improve the transient incontinence rates? We have some pre-op factors that may influence, so larger glands, older patients, diabetic patients, but we can change that. It's only for counseling, so I will not address this in this lecture. But we have surgery-related factors that are controllable factors, and we have to better understand the sphincter anatomy. We have to check the possible mechanisms of sphincteric damage and the surgical approaches to reduce this transient incontinence. So this is a very important paper for my understanding. It's from 1994 from Germany, and Dr. Dorschner have described the musculus sphincter urethrae as an independent muscle unit. There is nothing to do with the pelvic floor muscle. It's an independent muscle. We have connective tissue that completely separates it from the pelvic floor muscles. And it has 2 parts. The inner layer that is composed by smooth muscle fibers, that is the musculus sphincter urethrae glaber, or the lysosphincter. And the outer layer, that is the musculus sphincter urethrae transversus striatus, with striated muscle fiber that we will call the rhabdosphincter. And if we check this paper of prostatic anatomy for radical prostatectomy, it has really nice drawings that shows clearly these 2 components, the rhabdosphincter outside, it has this horseshoe shape, and the lysosphincter inside with an outer circular layer and an inner longitudinal layer. And it's very closely related to the mucosa of the urethra. This is another paper from the UK describing the circular and the longitudinal layer of the smooth muscle of the urethra. So you can see that the lamina propria is 0.5 millimeter, and then you have the lysosphincter with its 2 components, and then the rhabdosphincter. So the sphincteric mucosa is the lysosphincter. This is a concept that is not widely accepted, but once I incorporated this as a postulate, I could dramatically improve my continence recovery. The other important aspect is the shape of the sphincter, and if you see in this drawing, the sphincter is more proximal dorsally, so we cannot transect the urethra at 90 degrees. You have to preserve this longer length of the sphincter, of the mucosa, dorsally. And if you check the drawings from that paper, you see that the rhabdosphincter grows outside of the prostate, but the lisosphincter grows inside of the prostate up to the level of the veromontano. So you have to be aware of this when you are performing your sphincter release in HOLEP. And again, the dorsal mucosa is the lisosphincter, contains circular and longitudinal fibers of the lisosphincter. If you resect this dorsal mucosa, you are resecting the tip of the sphincter and you have leakage for a few months. That's a true problem if you are not aware of this anatomy. So what are the mechanisms of sphincteric damage? You may have direct thermal damage if you incise the dorsal flap or resect this dorsal flap. You have tearing of the sphincteric mucosa and damaging the circular layer of the lisosphincter if you do the blunt lifting of the lateral lobe, as we see in older videos from the first generation of enucleators. And you have a lot of traction of the sphincter mucosa and the sphincter if you cut the mucosa only at the end. If you perform the enucleation and the adenoma is still attached to the mucosa, you are putting a lot of traction on this lisosphincter. And you may detach the lisosphincter from the rhabdosphincter and damage innervation and vascularization of this flap. So if you watch hundreds of hours of videos on YouTube and see different surgeons, you can group two groups of apical mucosa divisions: the early sphincter liberation and the late sphincter liberation, okay? The early sphincter liberation, you incise the mucosa before the enucleation, and then you can avoid traction and tearing of the mucosa and reduce this transient incontinence. But sometimes you don't know where to cut. You may risk have thermal damage of the sphincter if you cut in the wrong place. And you have the late sphincter liberation where you do the blunt lifting. You are never cutting, using energy into the sphincter, but you put a lot of traction and tearing, and you have more transient incontinence. But you know where to cut, you avoid this thermal damage. And the most common mistake for thermal damage is during the 2 or 3 lobe technique. When you start the 12 o'clock incision at the bladder neck and come backward, you may pass the right spot. You are looking up, you can't see the vero to know when to stop, and the risk is that you extend it too distally and you are damaging the dorsal mucosa and the sphincter at this site. This is probably the most common mistake that may cause long-term incontinence. If you avoid this, you will probably not have long-term problems with incontinence in your patients. And how can you prevent this? This is how I do today. You have to create an anterior reference point at 12 o'clock, okay? This reference point is your distal limit of dissection anteriorly. You will incise the dorsal mucosa always from medial to lateral. You are not going to cut like pointing up. You are going from that point to the edge of the previous incisions. So this is the technique from McGill University video from the blunt lifting of the apex without incising the mucosa, okay? You see the tearing of the mucosa and the traction that you cause on the sphincter. You see the lateral lobe and you go inside, blunt lifting, and you put the sheath between the flap and the adenoma, okay? You avoid cutting the wrong place, but you create a lot of traction in the sphincter and a big tear on each side of the vero, okay? And when you do this, you have to cut the aftermucosa after the enucleation, okay? If you cut here, you are resecting the dorsal mucosa and resecting the lisosphincter. So you can't do that. You have to cut close to the adenoma and preserve this dorsal flap, and then you have a better continence recovery. It will leak for 1 month or 2, but the patient will be fine after this flap attach again. So here you avoid thermal damage to the dorsal mucosa but you have a big tearing of the sphincteric mucosa, damaging the circular layer, and a lot of traction. So the second way is to use endoscopic landmarks to perform the incisions, okay? You have the veromontanum as the most important landmark. You have the convexity of the right lateral lobe, and you have this wrinkle sign or Nesbit sign as the limit of the sphincter. And your incisions should be placed like this. As you see, you have to come distally, turn around, and go proximally near the 12 o'clock position. Iraoka was the first urologist to describe endoscopic enucleation. In 1983 was his first report, and then in 1987 and 89 he has publications with nice pictures, and he used a Collins electrode with monopolar energy to perform this initial incision, this a circumferential incision at the wrinkle of the external sphincter. If you see his drawing, he has this oblique incision as he preserved a longer dorsal flap of mucosa. And he does this sphincter liberation before the enucleation, preserving the integrity of the mucosal ring covering the sphincter. Dr. Fernando Gomes Sancha, in 2014, have described a similar technique using a green light side fire fiber, creating the white line as the proximal limit of dissection. He released the sphincter before the enucleation, preserving the integrity of the mucosa of the sphincter. And in 2019, he described a very similar technique using holmium laser and reported a very low rate of incontinence after surgery. And this is probably the best online resource today for those who want to learn HOLEP. He has a very excellent YouTube channel with almost 30 commented surgeries. So you should visit if you want to see HOLEP. But there are different ways to release the sphincter before the enucleation, okay? Another technique for early apical release was described in 2013 by Dr. Sung-Jun Oh from South Korea National University. And it's called the curtain opening incision. And we have adapted this technique for the M-block approach because Dr. Oh used the 3-lobe technique, okay? So basically, we have this, we start with the inverted U incision and we find the posterior plane. When you have the mucosa under tension, before it tears, we do this first relaxing incision of the mucosa vertically, okay? I like to see where I am before I perform this incision because I know where to cut. And then you progress with waves of enucleation. And when the mucosa is under tension, you perform a second incision more oblique toward the bladder. Remember, you should follow that curved line and until you reach 2 o'clock. And then you rotate the scope, you look at the vero, and you create this anterior reference point as a distal limit of dissection anteriorly. And the final incision is always from medial to lateral to avoid detaching the flap from the fossa. And then you find your plane again, and you can connect the anterior reference point from the lateral dissection. And then you do the same with the other side. Another advantage of the M-block approach is the symmetry. You always have your other side to work as endoscopic landmark to know if you are in the right place or too far away. So this is the idea of the open curtain. You perform the first incision like vertically, the second one 45 degrees toward the bladder, and the third one from the anterior reference point to the edge of the previous incision. This is very, very, very important. The anterior reference point should be placed at the level of the veromontanum because if you check this drawing, the lysosphincter cover the vero. So this dorsal flap is the lysosphincter. You have to preserve the dorsal flap. So since 2017, my technique is a totally in block, no touch, because I can be in the right plane. I have no more capsule perforation. I have much less residual adenoma, and I can preserve the bladder neck with early sphincter liberation using the curtain opening incision. So I avoid traction, tearing, and I have no transient incontinence. Almost all my patients are pad-free in the first office visit, 14 days after surgery. And this is the final aspect of the sphincter. You want to avoid any tearing on each side of the vero and a longer flap dorsally and a completely empty fossa with no residual adenoma. And if we think about the urethral anatomy, it has two narrow parts, the subnavicular urethra and the bulbous membranous urethra. And sometimes it doesn't fit the 26 French sheath. If we see the resectoscope, they are not very smooth. There are elevated steps that during the introduction, it sometimes get blocked at the tip of the penis, and you may have a lot of trauma during the introduction in the smaller urethras. So the first option to face this problem is to adjust the urethra to the instrument. You can dilate the subnavicular urethra with a metallic dilator, but you have this circumferential trauma, and this will increase the chance of scar formation because it will see a circumferential scar. So this is not the best way to deal with the small meatus. The best way is to use an Otis urethrotomy, because you have a linear incision and then you have a linear scar. It's very rare to have a circumferential scar if you are performing a linear incision and widening the distal urethra. This is a randomized clinical trial from South Korea, where they used Otis in 32 patients and no dilation in another 31 patients to check the safety for the urethra. And in the Otis group, no patients had stricture, and in the no dilation group, 60% had stricture. So Otis might be a safe option for if you are using a 26 French sheath. But in Brazil, we don't have Otis. You can't buy Otis. Nobody knows how to use it. And there is an option. You can use a conic dilator to check the diameter of the urethra before surgery. So you see that it's a small meatus. You do an hydrodistension with silocaine, and you do this dorsal meatotomy using an 11 scalpel blade. It's the same effect of the Otis, and it completely fixes the problem of the subnavicular urethra. And you gain almost 4 French with the incision, and then you can dilate a little bit because it will tear on the already incised spot. But what about the membranous urethra? Is it safe to dilate? Should we incise the sphincter, the membranous urethra? Probably not. This is very unsafe, and you may end up with a stricture. Another problem is the greater effect. If you see the distal tip of the sheaths, it has these small holes that has a lot of friction, especially in a tight membranous urethra, and you have this like this vegetable grater. And if you see in some videos, the dorsal mucosa is completely damaged by this friction. And you may have sphincter injury too. So the second option is to adjust the instrument to the urethra. In TURP, you have to use the 26 French sheath because you have to use the 24 French loop. You can't downsize the loop without compromising the resection efficiency, unless you are treating a very small gland. But in HOLEP, you are using a 550 micron end 5 fiber. It's 0.5 millimeter. You don't need a 26 French sheath. You can use a 24 French sheath. There is one available from Richard Wolf, or a 22 French sheath, and even an 18.5 French sheath from RZ Medicine Technique. So this is what I'm using right now. I'm using an 22 French sheet. I started 4 years ago. It's from gynecology catalog. It's used before for hysteroscopy as a monopolar device. And I asked them to develop the laser working elements. And then I have tested, and they have included in their catalog, is commercially available. It's a company from Germany, from Tuttlingen, the same city of car stores, and it's very high quality. And it's a continuous flow, rotatable 22 French sheet. It uses a 2.9 millimeter scope. Our standard cystoscope is 4 millimeter. This is 2.9. It's a little bit smaller, but you just adjust the zoom of the camera and the quality of the image is perfect. And I use this for all sizes of prostates. And 1 year later, I have found that there was a smaller sheet for gynecology. It's 18.5 Charrier, and I ordered them the laser working elements. And now most of my glands that are less than 80 grams, I'm using the 18 French sheet, and it's a very large gland. I use the 22 French. If the patient is using a Foley catheter for more than 2 weeks, the urethra is dilated, it's like pre-stented, and you can use the 22 French safely. But how can you morcellate? At the beginning, I used the standard 26 French nephroscope from stores after the enucleation. You may say, oh, but you damage the urethra anyway. But the time of the urethra stretched may compromise vascularization. So I think it's better to use the 26 French for 10 minutes after enucleation than for 2 hours. And then there is a smaller solution from Richard Wolf. It's a 24 French sheet, outer sheet with a standard long nephroscope. It works very well. But now we have this Slim Morsoscope project. It's a fiber optic morsoscope that fits the 22 French outer sheet of the resectoscope from RZ. It's fiber optic because you need a smaller optical component to fit the smaller sheet. It has a 5 millimeter channel. That's what you need for all morcellator blades. And it fits the 22 French outer sheet. And it has 2 large irrigation channels, so you have good inflow, which is very important for the safety of the morcellation. You want the bladder full all the time to avoid morcellating the bladder wall. But one swallow alone does not make a summer. So I need more people involved to make this slim HOLEP and the ultra slim HOLEP a reality worldwide. I'm having a lot of acceptance from many peers from different countries on Twitter. Many of them have contacted me as soon as the new morsoscope will be available. If you want to try it, please contact me and I give you the contact of the manufacturer. I have no conflict of interest, but they were the only company that heard me, and I'm asking for this for more than 3 years, and it's almost ready. They have promised me for this month, and I will try it. If it works perfectly, it will be available probably up to June. So Mohannad asked me to put a video. This video was published with my paper from the Andrologia journal last year. It's the low power, totally in block, no touch HOLEP using the smaller sheets. So we start near the vero. This is the easiest place to find the right plane, especially lateral to the vero. So if you do this inverted U incision, you see that I don't use the purely blunt movement to avoid bleeding. I like to incise everything. And then once you see the plane, you progress in waves of enucleation. You make wider and wider Cs, And when the mucosa is under tension, before it tears, you have to do this relaxing incision. It's a vertical incision at the beginning. And you have to go a few millimeters to incise the muscular layer of the lysosphincter. And then you do this long, effective enucleation movement from one side to the other side. And then you do the same in the other side. And when the mucosa is under tension, you can perform the second mucosal incision until you reach 1 or 2 o'clock. You cannot cross the midline because you are probably resecting the tip of the lysosphincter if you are resecting the dorsal flap. So you have to stop at 1 or 2 o'clock, and then you go to the vero, you check the distal limit, and you create the anterior reference point. But I like to do everything symmetrically. So after I finish one side, I like to do the same on the other side, the first vertical incision, and then you complete the apical enucleation of the lateral lobe. You see that I'm trying to coagulate simultaneously, no blunt dissection, and then the second incision. Today I'm doing a little bit different, but it's almost the same. And then you rotate the scope. The fiber must be at 12 o'clock. You check the vero, and then you create this anterior reference point. And the final incision must be always from medial to lateral. So it's the finishing the curtain opening incision. This curtain term is used from different surgeons for different things. This is the term used by Dr. Sung-Jun Oh in his paper, but sometimes the mucosa under tension is called curtain too. And here you do the same in the other side. And you see it's much easier to cut this small stripe of the mucosa if you have already performed the first 2 relaxing incisions. And then you go from below again. But once you have incised all the apical mucosa, it's easier to detach the adenoma. And then when you connect both sides at 12 o'clock, you have this circumferential enucleation movement, and the sphincter is completely liberated, and it's much easier to finish the enucleation. It's very important to understand that the fossa has a somewhat spherical shape. So first you are pointing outward, but then you have to point inward because it starts to close after the equator of the prostate. So we have to respect that, or you may risk going outside of the prostate, especially laterally and from below. So it's very, very nice to do this circumferential enucleation. Honestly, I'm not sure if I can perform a 3-lobe technique right now. I have more than 700 HoLEPs, and I can only do HoLEP safely and reliably this way. This is an important landmark. You see, there are circular fibers of the bladder neck and radial fibers of the bladder submucosa. And then you know you are at the bladder neck level. I like to complete the dissection of the bladder neck before entering the bladder for 2 reasons. First, because I keep the irrigation inside of this small cavity, so I don't lose fluid to the bladder and I don't have bleeding into the bladder. So I like to incise everything to dissect the bladder neck until 5 o'clock and 7 o'clock. And after that, I just incise the mucosa. You see, in this case, the patient has a very large median lobe, And this is absolutely no problem with this technique, because you go around the median lobe, and from lateral to medial, you go under the median lobe. And sometimes in very large prostates, you can't even enter the bladder, because the median lobe increase the length of the prostatic urethra. And with this technique, you go around this large lobe, and you can deal with very large glands with no problem. The posterior bladder neck is the trickiest part, because it has a 90-degree angle from the posterior wall. So it's very important to do the dissection from lateral to medial. Sometimes you don't have enough traction if the adenoma is intact, and you have to perform one bladder neck incision at 5 or 7 o'clock to get mobility of the adenoma. But the adenoma is already avascular, and you have no bleeding during this bladder neck incision. So that's it. After that, you have to check the hemostasis and do your morcellation. So I'd like to thank you again, Mohannad, for the invitation. It's an honor for me to be here. This is my contacts, holepbrazil with NZ, @gmail.com. I'm on Twitter. I'm doing a dopamine diet. I was too much on Twitter, like 20 times a day. Now I try to look once a day. And I have a YouTube channel. I don't have as many videos as Dr. Sancha, but this video is on YouTube, and I have an unedited video too, if you want to see the technique. I will try to upload more videos in the next few months, but I have a small child, 11 months old, and an older child that is learning how to read at home, because schools are closed because of COVID pandemic. So I have a lot of family duties, but I promise I will increase my video database on this YouTube channel this year.
Thank you so much, Dr. Felipe. It was really a great, amazing presentation. I personally learned a lot. So before we go to the questions, I just want to discuss with you regarding the learning curve, because I think HOLEP is gaining a wide acceptance worldwide, but many people, they have difficulty in learning HOLEP, or they have the fear of learning HOLEP because of the steep learning curve, as was published in many articles. Can you share with us your experience regarding overcoming this learning curve, and what's your advice for the people who want to start HOLEP?
I believe the safest way to learn HOLEP is to find a mentor, okay? Ideally, you should do a fellowship. You finish your residency and you spend 1 year in a HOLEP center, and you learn in situ everything, okay? But this is not possible. You don't have so many centers available, and especially in Brazil, I had no HOLEP center. In Saudi Arabia, you don't have too many HOLEP centers, so you have to move abroad. It's expensive. You may have a family, and it's not possible. So I had a self-taught learning curve, which is quite challenging, because you have nobody to ask for help, and you have to dedicate a lot of effort. You spend a lot of money traveling abroad, and I don't know if this is very reproducible, okay? I was really obsessed with HOLEP. I watched videos every night on my iPad before sleep, like 1 to 2 hours every day for 2 years to gain my proficiency. But most enucleators are very nice people, and they are willing to accept a visit. And I think it's important to see, before start your first case, one high volume surgeon somewhere near your place. If you have someone doing HOLEP in your country, I think you should find a way to have some mentoring from this person. I'm starting a personal mentoring program in Brazil next week. I'll go to Brasilia to help a friend. He have just bought the laser and the morcellator, and it will be his first cases. We are planning to have 50 cases before he start doing alone. I think this is the safest option for the patients. But again, this is maybe not possible. So if you are doing a self-taught learning curve, you should look for easier cases like 60-gram prostates. You don't want to enucleate small glands because you don't have a very well-defined plane, and you don't want very large glands because it has more bleeders. The size of the vessels, it's depends on the size of the gland. If you have a 200-gram prostate, you have very large vessels, and you may have a hard time for coagulating. So you should be around 60 to 80 grams. I think this is ideal. You can convert to URP if you have any morcellator problems, and you should do your first 20 cases in this size range. And then when you feel comfortable, you try to move to larger and larger glands, okay? But I think it's easier to start with 60 to 80 grams prostates. I don't know if you share the same feeling.
Yeah, I agree with you because as you mentioned, if it's small, it will be hard to find the plane and you may perforate easily. And if it's too big, again, you will be lost because you will be disoriented easily. So I guess, as you said, 60 to 80 grams is the best size to start.
But at least in the first few cases, to get the idea of the working distance, the fiber tissue distance, how to hold the resectoscope, you have to see with your own eyes, visiting someone, and ideally to get someone into your hospital to start your first cases. I know in the UK, they have a Holy mentoring program where they have a visiting mentor for 2 days, and they do like 5 cases or 3 cases. But I don't know if this is enough. Honestly, I think you need at least 20 cases with a mentor, because less than that is not safe for the patient. You have a high risk of transient incontinence. There are some publications showing that the presence of a mentor in the room reduce the risk of incontinence in 84%. So if you think about the patient, you should have a mentor for 20 cases.
I think, as you mentioned, the key is to see a lot. You have to see a lot of HOLIP cases, either through video or visiting someone who's doing a lot of HOLIP cases, because the problem with HOLIP, it's a 3D anatomy. So you have to imagine the prostate in a 3D fashion. And also you have to have the feeling of enucleation, of finding the right plane. You have to differentiate which is the right plane and which is, when you are close to the capsule and when you are not. So that's why I think the issue with the learning curve. Okay, so now we move to the questions. The first one is about which lens you use, 12 or 30 degrees?
I use the 30 degrees. I know many surgeons that use the 12 degrees. Actually, I have never tried the 12 degrees, so I don't have an opinion. I bought my first one 30 degrees because that was the one I used for cystoscopy, for double J, for everything. And in Brazil, we want to have, in my city, I had to buy all my equipment. So my laser is not from my hospital. I bought from my pocket. My endoscopes, I bought myself. My morcellator. So yeah, I have the 30 degrees, but you can use 12 degrees. I know Cesare Scofoni, Karin Lerich, they use 12 degrees, and I think it works fine. Mm-hmm. The 2.9 millimeter scope from RZ are available in 12 and 30 degrees, so there is no big issue here.
Okay, so there is another question regarding the laser setting. Which laser setting you use when you start at the apex? Is it different? Do you change the laser setting depending on the location, or it's the same setting?
I use the same setting in the whole surgery. When I started, I used an used laser. I bought an used laser. It was a trimodine from California, from the US. It's an 80-watt laser, but with 2 joules, I couldn't get 80 watts. I could get 60 watts. And after 1 year, it overheats with 6 watts. So I had to decrease the frequency to 25 hertz and 2 joules. So most of my first cases, my 400 cases was 2 joules, 25 hertz during all surgery. That machines only had the short pulse available, but now I'm using the Quanta laser, a 60-watt Quanta laser, and I started using 2 joules and 30 hertz. But my impression is that the pulse of the Quanta is like more powerful than the Trimedyne. And visiting Karin Lerich in Germany, in Berlin, she uses 1.2 joules and 60 hertz with the 120 luminous laser. And it's amazing. For me, she's probably the most skilled HoLEP surgeon in the world. It's really worth watching her surgery. I think there is a recent surgeon in AIS channel, Karin Lerich, using Moses. And it's great to see her technique. With 1.2 joules, you can work closer to the tissue. And this is especially important for the 18 French sheet, because I don't have that space with the 18 French sheet. So now I use 1.2 joule in all my cases. And with the 60-watt Quanta laser, I can reach 35 hertz with the 1.2 and only 30 hertz with 2 joules. So I can increase a little bit the frequency, which I believe increase the enucleation speed and efficiency. So I use this. If the plane is not well defined in the right pedal, I can put more energy. So sometimes I use 1.5 or even 2 joules. And you can modulate the pulse duration too. The short pulse is good for opening the plane. You have more mechanical displacement. And the long pulse is better for coagulation. It has less mechanical displacement. So usually in the right foot, I put long pulse for coagulation.
I had the same issue when I started HoLEP in Saudi Arabia almost 2 years back. I had the 100 watt from Luminous, but it was an old machine, like it's 13 years old. So that's why I didn't go very high. So maximum I went up to 60 watts. And it worked great for the first few cases. And then we bought the new machine, the 100 watts, the 2 pedals. So usually I use 40 watts or 45 watts for coagulation and 80 watts for enucleation. And I think for beginners, it's good to start with a low power. So they see the planes better and they don't do perforations more often. Okay, so now we move to the next question regarding small prostate. Like if you have a small prostate, 30 gram, 40 gram, either with a middle lobe or high bladder neck or just bilateral lobes, how do you deal with these? Yeah, because I think the risk of bladder neck contracture is more if the prostate is smaller.
Yes, the challenge of the small prostate is that the patient needs treatment, okay? They have obstruction, but the pathophysiology is not the same. You don't have a large adenoma compressing the prostatic urethra. You have a muscular component, and these patients have a high risk of bladder neck contraction, okay? So I had, in my 720 cases, I had 7 cases of bladder neck contraction, and all of them were in small prostates, less than 40 grams. The problem is that the other solutions for the small prostates also have problems. The guidelines, they recommend incision of the prostate. So you do a transurethral incision. You come from the urethral meatus and you incise the bladder neck and the prostate up to the vero. And I did this in 10 cases with the laser. It's good for hemostasis, it works well, but I had a very high reoperation rate. 30% of my cases needed a new surgery in 1 or 2 years. So I was really frustrated with my results. I don't know if I did something wrong. I was not brave enough to cut to the grass, but it was not good. One of the cases, the patient had a bladder neck contraction, and then I did the HOLEP, and he was fine. The other had dysuria, pain during micturition for the long term. And the third one is a very interesting case. With the full bladder, the grooves were open. He had a very strong stream, but as the bladder was empty, at the last 150 millimeters of urine, he had a very long, weak uroflow, and he had a lot of post-void residual volume. So he was very unsatisfied, and I did his HOLEP, and he was perfect after that. So I started to do HOLEP in all my cases, and what we see if you enucleate these cases is that the bladder neck opening is very small in the end, okay? And I try to preserve the bladder neck because I think the main component of bladder neck contraction is if you resect and you create a gap between the bladder wall and the capsule. And this gap, there is no tissue for reptilization, and you may increase. So I started to preserve the bladder neck and incise at the end, okay? And then I haven't had any case after that. Another resource is to preserve some stripe of mucosa from the vero to the trigon. So you enucleate the lateral lobes and you preserve a stripe of mucosa, either at 6 o'clock if the patient has no tissue. If it has a median lobe, you can preserve the anterior commissure. I know the group from Turkey, the omega shape technique, they preserve the dorsal. Thomas Herman is doing something like this with bipolar energy. I don't know if this may compromise the long-term outcomes in the future, but it's one option to avoid bladder neck contraction. And I think, but I'm doing HOLEP in all my cases, every size of gland. In less than 30 grams, I try to preserve some mucosa at 12 o'clock or at 6, and to incise the bladder neck as much as possible before any perforation, to have a wide open bladder neck at the end, and to have reptilization before the contraction.
So you don't do any incision only. You do HOLEP, then you incise the bladder neck after you finish the HOLEP.
Yes, for the last 2 years, I have abandoned incisions only because my results were very poor.
And your incision, you do it at 6 o'clock or 5 and 7 or?
When I was doing incision, I was doing at 5, 7, and 12 o'clock.
No, I mean after
Mercedes-Benz incisions.
After you finish HOLEP.
After HOLEP?
Yeah.
Yes, after HOLEP. But the deeper incisions are at the direction of the meatus, okay? So I go on both sides.
5 and 7.
For many reasons, because if you do one incision at 6 o'clock, you have a less space, and you need 2 incisions to get a wider. If you go lateral, you have less tissue, you have easier to have perforation. So I think if you consider the shape of the prostatic fossa is like this, so you have more space to incise here before have any perforation.
Great. So we move to the next question. It's regarding the rate of retrograde ejaculation. And this takes me to another question. Do you do any ejaculation sparing techniques?
I have tried at the beginning to preserve the paramontanal tissue, so the tissue around the vero, and it was not very good. I had some cases, but it was like 20 to 30% of the cases that preserved ejaculation. I tried to spare the dorsal mucosa until the thinking like the aquablation method, that maybe it could help but it didn't help. And if the patient is very young and wants to preserve ejaculation, what I do to preserve is to enucleate only the median lobe and to preserve 1 centimeter of tissue above the vero. So you preserve the lateral lobes, you preserve the 1 centimeter of tissue above the varus because you have the ejaculatory ducts in oblique fashion here, and then you remove only the median lobe. And usually the patient has good bladder function, they are young, and they get better. And I tell them, you will be fine for 5 to 10 years, and then you need another surgery in the future. But after that, you already have 1 or 2 kids, and you can, and there is a publication from Steve Kaplan in AWA, a poster with a median lobe only TURP with reasonable durability in 10 years and 92% ejaculation preservation. So you can get over 90% of preservation of ejaculation if you preserve both lateral lobes and 1 centimeter of tissue above the vero, okay? So there is a lot of marketing from the industry of the new devices as the only options for preserving ejaculation. But if you don't have access to these single-use devices and you have a resectoscope, you can resect the median lobe and improve the patient's micturition without compromising ejaculation. And with holmium laser, you can do this with an 18 French sheet, which in my urethra would be my option.
Okay, so we'll take 2 more questions regarding the perforation during HOLIP, capsular perforation. How do you deal with that?
Usually, you can recognize that you are almost perforating and do not move forward. If you see a almost perforation, you have to stop there, you turn around, you progress somewhere else, and then you come from the base and you cover the perforation, the cat maneuver, and then you release without increasing perforation. This is easier with the block technique from my point of view, and I think it's the best way. But if you have a perforation, you have to classify if it's a free perforation, like you are losing fluid, you should stop, put a Foley, wait 1 week, and then you come back, you finish your surgery. But it's a small perforation, sometimes it's covered by fat tissue, you see there is no fluid leakage, you can just follow your surgery.
And I think the most common reason for perforation is when you do blunt inoculation in a very fibrous or inflammatory stuck gland. I think when you do that, you have more risk of perforation. And I think it depends on the area also. The bladder, if you are under the bladder neck, you will have more risk for perforation too.
Yes, I agree. I'm not really fan of blunt dissection only. I think we should explore the bubble. That's why I only use holmium for my endoscopic enucleations. I have some experience with monopolar enucleation. I had 38 cases, but the results are not the same. I did a much more traction on the sphincter, more transient incontinence, 2 to 3 days with a catheter, more bleeding after surgery. So I don't do it anymore, but it's something you can use to start. But I really think you should have a morcellator to start doing HOLIP, because if you try to resect after nucleation, you increase too much the surgical time and the urethra time and the urethral trauma. So this is not good for urethra.
Okay, so we'll have the last question. It's regarding, you mentioned the advantage of using a small resectoscope sheets, but how do you guarantee the flow, the irrigation flow through these small resectoscopes?
Actually, this was my doubt before my first case, okay? Will I have enough flow to perform HOLIP with this sheet? And with the 22, I can guarantee it's the same flow. if you do en bloc, you'll be fine, regardless of your experience. Okay, if you can do with a 26, you can do with a 22. Okay, so I don't see any reason to do Holic with a 26 French anymore. With the 18 French, sometimes you have a little less flow than you should have. Okay, but with some learning curve, you improve your technique to be more hemostatic. And right now, I can use up to 100 grams. You take like 5 to 10 minutes more with the 18 French than with the 22 French. I know in some countries, the surgical time is the most important factor for cost of surgery, but not in Brazil. The fiber cost in Brazil is much more important than the OR time, for example.
So this concludes our webinar. It was a great pleasure and an honor to have you with us, Dr. Felipe, tonight. It was a really enlightening and informative presentation. I would like to thank the audience for taking the time to be with us. Also, I would like to thank Saudi Pelvic Floor Society, and a special thanks to Dr. Badr Al-Saeed and Dr. Sulaiman Al-Mutairi. Without their help, we wouldn't be able to do this webinar. And finally, I would like to thank our sponsor, Luminous. Thank you so much.
So, bye-bye.